Hi, everyone. Hi, Nico. Hi, Tony. Hi, all the people from the Venus Symposium in the United States. This is Daniel, and tonight I will be talking about our abstract, which is called the use of topic sevoflurane as a local anesthetic for chronic ulcers in lower limbs. This study was performed at the Hospital de Especialidades de EUGENIO ESPEJO in Quito and was performed by the vascular and endovascular surgery fellows from the Catholic University in the same city in Ecuador. So hi everyone and welcome. About a little bit about me. My name is Daniel Arroyo. I'm a fourth-year vascular and endovascular surgery fellow from the Catholic University of Ecuador. I'm also a member of the Paraguayan Society of Phlebology and Lymphology, and I'm also a Science Health Junior Professor at the Technical University in Ambato. A couple of years ago, I had the opportunity to make a rotation with Tom Maldonado in NYU Langone Medical Center in New York City. No disclosures for this conversation. And when we talk about chronic leg ulcers, it's a really big problem in elderly. As we all know, people who are over 60 years old have a really problem with it. The incidence is a little bit higher in Latin America, especially in Argentina, Brazil, Colombia, Ecuador. But in UK, it's still 3%. And in the United States, it's 1%. And when we find some literature, we saw a study made in Tufts University in Massachusetts, where they found like 80% who had a chronic venous leg ulcer, they have pain, mild to moderate pain in intensity. They have discomfort in timing because some of those ulcers, it was really hard to heal. Some of them took up to 4 to 6 months to heal. And another really trouble was the cost. They say that they spent at least $86 every day of healing. So they have a lot of patients. It was around 19 patients. So it was a really high cost. But what is the purpose? What is the objective of this study? We want two things, that is reduce ulcer size and relieve pain. I think those are really big deals. So methods and materials. This is a retrospective study. We performed from October to November in 2019. We recruit 10 patients who previously signed consents. So what kind of patients we have? We have patients around 60 years old. Most of them were females. And this is, I'm going to tell you something that we didn't know the etiology of the ulcers. We just get chronic ulcers, chronic painful ulcers. And when we start treating it, after that, we did perform ultrasound, we did biopsy, and we found that 6 of them were actually venous, 3 of them was gangrenous pyoderma, and 1 was vasculitis. They have at least around 17 months living with it. The surface area was around 16 square centimeters, and they have at least 2 ulcers in 1 leg. So what were the inclusion criteria? Chronic and painful ulcers, failure to traditional management, and the ulcers should be located around the ankle. We get rid of every other ulcer in any other part of the body and any kind of allergy to anesthetics. So how we evaluate at the baseline our ulcers? We use this Waldin score, which is a German score, use it for evaluation of different kind of wounds. They use it for diabetic foot ulcer, for chronic venous ulcers. So that's why we used it. And it has been proved in Europe for many years. So this is an easy score, which evaluates 3 things. As you can see on the screen, we have to evaluate granulation tissue, color, and consistency. Granulation tissue, it's measured by percents. When we have granulation in less than 25%, they have no points. When it's around 25%, is 1 point. When you have 50%, 2 points, 75%, 3 points, and once 100% of completely granulated, it's 4 points. What about the color? Color, if it's pale, or I mean, it's kind of white, it's no points. When it's pink, 1 point, and when it's red, it's 2 points. And when we talk about consistency, when it's spongy, like soggy, with no points, and when it's solid, 1 point, and that gives you a total of 7 points. Sorry for that, as when it's completely healed, and it's okay. And for intervention, what we did, all the time that patients come to the wound center, we get rid of all the compression stockings, the multi-layer bandages, and we made a little cleaning with saline. Then after that, before the debridement, we applied 1 milliliter of medication for every square centimeter of the ulcer. We didn't want to exceed 10 milliliters because we don't want any kind of reaction on those patients. So after that, we wait like 2 minutes. And after that, we start doing any kind of other procedure, applying some hydrocolloids, or if that was the case. But at the end, we make some compression, whether it was stacking compressions or multi-layer compression. As well known, that's the key of the stone of the treatment, compression. So what were the results? And I'm going to share you later some of the pictures, because sometimes numbers and tables are kind of tough. So this is the baseline. This is when the patient came to our clinic. And as well known, most of them, they have poor granulation tissue. It was kind of pink. Let's say the consistency was really soft. And we start applying our procedure. And what we notice is like 7 days after that, we start seeing that granulation tissue was appearing, was getting bigger. So that was really good for us. By the second week, we saw that 60% of them were already healed. And that was a really relief for us. By the 4th week, we saw that only 1 patient still had some problems, but it was around 90% healed. So I'm going to show you pictures. Pain medication is really important. As I told you before, when we recruit them, they had severe pain, and they already were taking opiates by itself. They were taking opiates plus neuropathic medication, or opiates plus NSAIDs. On the other hand, after the procedure, after the medication, after the procedure, and after the improvement of the ulcers, we saw that the de-escalate medication. That means instead of taking opiates, they were taking a soft medication like Tylenol or ibuprofen or something more light. That was amazing. And they said that by the 6th week approximately, they stopped taking medication. So here are two patients, 2 of the most difficult patients that we have. At the beginning we saw by the day 0 at the baseline in the upper left hand, we saw that this patient has a really, really bad tissue, poor granulation tissue, this soggy, and you have even necrotic tissues here. So we start making a really, really good debridement. And by the 2nd week, we saw that it started to heal much better. And then after that, by 1 month later, we saw that it was like completely healed. So it was really, really, really amazing seeing this in those patients. In the bottom left, we have this patient who has a really huge ulcer here. And after applying all medication and doing all the procedures, we saw this, that was impressive. And this is from the last pictures we have. As we know, I mean, our procedure is not what it heals, but it helps a lot. We know that what it really heals is compression, or compression stocking or compression multi-layer bandages. But this helps to debridement. Debridement will help to develop granulation tissue, which what we wanted. Conclusions. This intervention should be considered because of easy application, safety, because it's topic, quick adhesion, better debridement tolerance, which also help to develop granulation tissue. As you know, people just hate going to the wellness center because they get in a lot of pain. If they just quit going, and this is like something that comes going and on and on. So it helped a lot. And patient de-escalate pain medication, as I'll tell you before, they started on opioids and now they are on Tylenol. Some of them are not taking at all pain medication. And the most important thing is, like, as we all know, multi-layer compression or wearing compression stocking is the key of the stone. That's what really will cure them. But if you don't have granulation tissue, if you don't do the healing process as you should, compression stocking will not be enough for them. So once again, thank you very much, and bye-bye.